And then when to refer, again, 3 UTIs per year. It doesn't sound like a lot, but it's usually more than that. And then what we do is make sure they don't have bladder stones, because the bacteria can hide out in the stones, and they'll need to see urology for a cystolithoplasty. Make sure that they don't have an upper tract dysfunction. This is where the renal ultrasound and urodynamic study can come into play. Make sure they don't have the kidney stones or bladder stones. And these are all kind of interconnected, so there could be arrows in every direction. If they have hematuria or trauma, it's not unusual to have strictures or false passages in the urethra. And then again, if they want to change their bladder management, it's not unusual after a decade or two to go from a condom. Maybe they left rehab using a condom catheter, and now they figured out that their bladder pressures are high and are willing to use clean intermittent catheterization or even an indwelling catheter. We're nearing the end. The takeaways that I would love for you to consider is most people manage their neurogenic bladders using catheters, whether it's indwelling or intermittent catheterization. Secondly, the lack of sensation. Again, just always have urinary tract infections in the back of your mind for patients with spinal cord injury. This is the #1 issue that they encounter that require hospitalization. Annual screening, ask how they empty their bladders, and then if folks are happy with it. But if not, again, there's always opportunity to change the bladder management if it's not going well. And then refer to urology for cystoscopy, especially if somebody has an indwelling catheter. Other studies like urodynamics and renal ultrasounds can skip years once things have been stable for, I would say, like the first 5 years. What can you do as primary care providers? Download these checklists, go on the SCI website. We're trying to make it more accessible. There are videos on YouTube. This talk is being recorded as a reminder.